We would like to call Dr. Samrat Jankar. He is going to be speaking on clinical radiological integration. Dr. Samrat has been the backbone of today's meet, and I think he's done a wonderful job. So kindly enlighten us as to what else has to be done. Thank you.
I would request Darshan sir also to join. This is actually a pattern concept. This is a concept has been devised by Dr. Rojansukul sir and already published. And this is a wonderful concept which can be implemented in our routine, which will help us. So we are doing this is as clinical-radiological session, and few of the slides will be discussed by Dr. Darshan sir. He is the expert radiologist. So coming to session, what is the purpose of any classification? It is to simplify the communication between the clinicians. It is to guide the clinician about the complexity of the treatment option, guide the surgeon, estimate the surgical success and possibility of post-surgical, especially incontinence. So what we are following as a surgeon is PARC classification. There are many of the things are there. It is olden concept based on the pre-MRI era, and it has its own drawbacks. If you go, this is surgical classification based on the physical examination. They have done wonderful things in that era, putting up that classification. But it is useful in this present condition. So it is easy and simple, and based on only coronal plane, axial plane and other plane has been not taken, and basically it is a clinical classification. But here is the question. This is a pre-MRI era. We are having MRI available in every place, even in district place. It is mixed type of fistula in every class. Let's see, this is a high intersphincteric, low intersphincteric goes in intersphincteric. So that cannot satisfy, treatment might be different for different. If we take transphincteric type 2, low and high combined together, we can't afford to give us same operative procedure for both, because that will be a different for high, different for low. And also anterior high, posterior high is different. Data is skewed. If you see the data is telling about the 40% is intersphincteric and very less in a suprasphincteric, and subsequent the whatever papers from the PARCS itself, suprasphincteric number is decreasing. Present whatever papers are there, they are telling that suprasphincteric is iatrogenic, not actually the fistula. So the extrasphincteric, suprasphincteric are usually iatrogenic type. And these are the drawbacks. Our radiologist will talk on the our classification.
So what radiologists usually use is the St. James classification, and it helps in, it makes a description quite easy, but it may not always transform in what the surgeon wants. So I have just realized this over a period of time after communicating with Dr. Samrat, and it has really helped me to overcome my challenges as a radiologist, and also help the surgeon to some extent. Okay, so this is St. James classification type 1, 2, 3, 4 and 5. What it basically means is that type 1 is a simple intersphincteric abscess or a fistula, and the type 2 would be whenever the intersphincteric fistula is associated with an abscess or with any further ramification. It is type 2. When it comes to type 3, it is a transsphincteric extension, a simple transsphincteric fistula, not associated with any form of an abscess or any other ramification or division. When it is type 4, what it basically describes is a transsphincteric fistula associated with an abscess or maybe associated with a ramification. And the last variety is when there is suprasphincteric and extrasphincteric variation which is there of the fistulous tract.
So these are the drawbacks. MRI based, most widely used by radiologists, but more or less it is for the PARCS only, and same institute has come with this classification. Doesn't much help. We take classification, but it will create as question that should we use or not. That is a major problem. And also if we see, that is more or less same. What we are following as a radiology and surgical, our group, what we have been talking is Arun Rojansukul pattern, how it helps. So we will see radiological and clinical. Actually, the concept is the infection in intersphincteric plane always travel path of least resistance. It can go down from the low intersphincteric, it can go up from the high intersphincteric, it can cross in the low transsphincteric, it can go up as a low high transsphincteric. You can see that this will form the patterns as a natural pattern. Low intersphincteric intersphincteric fistula, it can form the low transsphincteric fistula as a type 2. And if it comes the anterior or posterior high transsphincteric, the spaces are different. So he is subclassified as an anterior high transsphincteric and posterior high transsphincteric. So last but not the least is intersphincteric high. These are the 5 patterns if we learn that will be useful as per the Dr. Rojansukul. So these patterns we will see one by one. The low intersphincteric pattern, the sepsis form internal opening travels across the internal sphincter and come out. That is a low intersphincteric fistula. If we see this MRI,
So just to help everyone get versed, these are T2 fat suppressed images, and what we see marked here, it is marked in the yellow part. It's a intersphincteric collection which is here seen on the left side. A simple variant, the blue line marks the internal anal sphincter, the red line marks the external anal sphincter, and whatever was marked in yellow corresponds to the collection which is there in the intersphincteric space.
so the treatment for this is very simple. We can do a simple fistulotomy, sphincter cutting option, better is option. So going to a low transsphincteric is the abscess which will travel from internal opening and crosses the subcutaneous part of external sphincter.
Okay, so let's begin. I'll again try to stop on the slide which depicts the pathology the best. This is a T2 fat suppressed sequence just to get you versed with the terminology. Okay, the entire fat is dark. It means that there is suppression of fat, and whatever bright and you can see stranding of the fat, that corresponds to the pathology. It is possibly inflammation which is associated with the tract or the abscess. Okay, you can see that the abnormality is there. We are going, okay, I'll stop at this point of time. Okay, so we are going from the foot end of the patient to the head end of the patient. Okay, this blue line corresponds to the internal anal sphincter, the red line corresponds to the external anal sphincter. That is the tract which is appearing anteriorly, going on to the right side, piercing the external sphincter somewhere at around 11 o'clock, and then it is forming a collection in the ischioanal space on the right side.
Going to low transsphincteric type, treatment option is simple, procedure is sphincter cutting procedure is a better option. Exception to that, if we are having anterior fistula in female, recurrent fistula, IBD post radiation, we need to preserve the sphincter. Coming to anterior high transsphincteric sphincter type, there will be a tract which is going anteriorly, which will mainly go the deep perineum space and come out. In a female or male, it will be a sphincter preservation will be needed. We need to appreciate on the MRI, that will be a better.
Okay, let's go to the next sequence. Again, this is a fat saturated T2 weighted sequence. When it comes to fistula, it is always T2 with or without fat saturation. All the bright areas are abnormal. Let's proceed further. Okay, I'll stop here. So again, we are proceeding from the foot end of the patient to the head end of the patient. What we see, the blue corresponds to the internal anal sphincter, the red corresponds to the external anal sphincter, and you can see the transsphincteric extension here somewhere between 12 and 1 o'clock position on the left side. I'm going to rerun the video just for convenience. That's the coronal plane that we are viewing. The bright structure is the urinary bladder. Okay, that's excellent to demonstrate here. Okay, so again, that's the coronal plane. The blue line corresponding to the internal anal sphincter, that's the levator ani. Somewhere is the superficial external sphincter, and that would be the subcutaneous sphincter. You can see the tract which is coming here into the left ischioanal space, and then is traveling into the perianal space, reaching up to the skin. All these are fat suppressed T2 weighted imaging because of the natural contrast which is created between the bright fistulous tract and the dark fat. This is a very convenient sequence for viewing the fistula. Should we proceed to the next slide?
Coming to anterior high transsphincteric, we need to take a simple message that it is going, they have shown more than 30% about the sphincter it is crossing. This needs sphincter preservation surgery. So we need to have a sphincter preserving option for this patient. Coming to a next type, posterior high transsphincteric, we have discussed that it goes to deep postanal space and comes out, and these patients are sometimes have some different type where opening can be a coccygeal opening. We may confuse with pilonidal sinus. These are the third 5% what sir claim is. These will directly cross from 5 o'clock to 7 o'clock without going to deep post-anal space. It come across. By and large, posterior high transpentric usually goes to deep post-anal space and come on either side, forming the issue horseshoe fistula or horseshoe abscess. So deep post-anal space carries here significant slot. So coming to a radiological section.
Okay. So sometimes what happens is that, just to help you with the imaging part, now in this part you can see the fat as bright, so this is not fat suppression. Okay, sometimes if we suppress the fat, the natural contrast itself is not very well depicted. So this is a non-fat suppressed T2 weighted imaging. All these bright areas that you see here is the abdominal tract or the abscess. That's the internal sphincter, that's the external sphincter. Let's go further in the video. That's the fat suppressed sequence, because you can now see that the fat is dark. Okay, the blue corresponds to the internal anal sphincter, the red corresponds to the external anal sphincter. We can see the tract which is piercing the external anal sphincter high posteriorly, and this is the horseshoe shape extension which is seen, the longer left limb and the shorter right limb.
And here also one thing we can note what madam has told. The infralevator abscess are connected with the deep perineum space. Here the abscess is going upper side into the deep perineum space anteriorly also. So that has been shown on the cadaveric image by Dr. Rojansukul patterns. So this type, if we are getting posterior high transpentric, one thing we need to take a message that these patients need a sphincter preserving surgery. So coming to a next portion, that is a high intersphincteric type of pattern. Here, the internal opening from there, the abscess goes up above into the intersphincteric space. From dentate, it goes up above intersphincteric space. It can come in a supralevator or it can go anywhere pararectal abdominal wall, even lower thoracic cavity. So this is a high intersphincteric type. So MRI we can see.
Again a fat suppressed T2 weighted imaging. We are now coming above downwards. Okay, so what you see here, that's the anal canal, the pubo rectalis, and you can see a collection which is seen extending across on either side of the midline, probably in the deep post-anal space. Am I right?
Yeah. It
We
is
are
an
quite high up.
intersphincteric space.
Intersphincteric, okay. And then we are progressing. Okay, just to get things right, that in this particular video, we are coming from the head end of the patient towards the foot end of the patient. I'd like to run the video once again. A fat suppressed sequence. You can see the rectum here, the prostate anteriorly. Okay, that's the internal canal, that's the pubo rectalis, the collection here going posteriorly. Now we are going caudally as well. So it is in the intersphincteric space, extending outside as well as extending above the level of the levator ani. This we have come lower. Can you just run it once again, please? Yeah. So this is high up, rectum, prostate. The collection begins here itself, intersphincteric, high supralevator, and then coming caudally as well.
So, as per Rojansukul's type, that is just this space, we can just do the intra-anal fistulotomy, divide above the dentate line, internal sphincter and curate the cavity, may not need any incision outside on the ischianal area. So coming to what they tell as a combined type, posterior high transsphincteric, high intersphincteric can come with a combined pattern. There will be a one track which is going ischianal, that is deep postanal to ischianal, and another one track which is going into the high intersphincteric, forming a supralevator abscess. So this is a bit of complicated type. If we have radiologists who will tell this, then it will be a very good for us to take a decision what need to be done.
Okay. Okay, so I'll restart the video. So here we are in the axial plane, foot end to the head end of the patient. A large collection which is seen in the presacral space extending along the left lateral pelvic wall and anteriorly. That's the sagittal image. Okay, you can see collection in the presacral space across the lateral pelvic wall, across the inguinal region, reaching somewhere in the left abdominal wall. Yeah, that's right. The axial images, that's the collection, presacral left lateral pelvic wall, the bladder extending along the anterior abdominal wall, that's the sagittal left side. You can see all the collection extending along the left lateral pelvic wall. All the black spots that you can see correspond to presence of air which is arising because of communication with the anorectum.
So to simplify what they tell as per publication is most common type what they are finding is posterior high transpentric, and least common is they are telling is interspintric, which is usually get a low transpentric confusion. So the purpose of making this combined pattern understanding with radiology, so we need to go for understanding along with radiologists so that they also know what we are expecting, and also we also will get what actually they want to speak to us, communicate from the report. Thank you.
As doctor, I'll just like to put it into words. The feelings and words, they should, match each other. Otherwise, if there's a mismatch, the patient falls into trouble.
Maharad is a Maharashtra Radiological State Conference is going on. All 5 radiologists with us to give us enlight about this.
Thank you so much for being here.
Thank you, sir. Thank you so much, sir.